focuses on behavioral and social approaches for physical activity promotion. Although the details are less important, a key concept here is that efforts in behavior change must be driven by one or more theoretical models. Several models have been used in studies of physical activity promotion. The most popular is the stages of motivational readiness and the social ecological model. These strategies help individuals become more physically active by using multiple approaches and problem solving. Social support is also an effective strategy for physical activity promotion. Almost everyone cycles in and out of being physically active. Some weeks are good, others are not. Weeks turn into months and then into years. Life circumstances and demands have a way of shifting priorities. Has this ever happened to you? Have you had to chance or stop an exercise routine because of life change? How did you work through it? What strategies did you use to continue to make exercise and physical activity a priority? Has this ever happened to someone in your family, or a close friend? What were the barriers for this person continuing to be physically active? Alternatively, have you ever wondered how someone can be physically active day after day, year after year? What do these people do to be successful? It is very crucial to use behavioral change theories as frameworks to guide physical activity intervention. Indeed, over the past 20 years, a burgeoning of theory-based studies in the physical activity and health promotion field has been observed. With many studies using one or more of the 7 theories listed above. Theories and models are important in that they allow us to better understand and predict individuals' physical activity behavior. 2. Provide a scientifically validated blueprint from which to formulate effective physical activity behavioral interventions. And 3. Enable us to organize physical activity behavior variables in a coherent manner. Simply stated, theories and models can help explain physical activity behavior, as well as suggest how to develop and implement more effective intervention methodology capable of influencing and changing such behavior to a greater degree. The first theory that is widely used in behavioral change is health belief model. The basic components of the health belief model are derived from a well-established body of psychological and behavioral theory whose various models hypothesize that behavior depends mainly upon 2 variables. Behavior depends upon the value placed by the individual on a particular goal and the individual's estimate of the likelihood that their actions will achieve the goal. When these variables were conceptualized in the context of health-related behavior, the focus was on either the desire to avoid illness or, if ill, to get well. B. The belief that a specific health action will prevent or improve illness. This slide demonstrates the concepts of the health belief model. An individual's perceptions of the degree of both susceptibility and severity provides desire to take action, and the perceptions of benefits provide the preferred path of action. However, an event or cue is necessary to trigger the decision-making process and motivate an individual's readiness to take action. These cues to action might be internal, external, or both. Internal cues could include perceptions of bodily states such as dizziness, elevated heart rate and shortness of breath. External cues could include mass media communications. Theory of planned behavior is originally designed to predict single-instance behavior. To increase individuals' physical activity levels, identifying factors that influence the decision-making process is critical. A model that has been used to understand this process is the theory of planned behavior. The theory of planned behavior was developed on the basis of its earlier work, theory of reasoned action. The theory of reasoned action emphasized intention as the most immediate or proximal factor of desired behavior change, a factor influenced by two constructs: attitudes and subjective norms. However, the theory was later expanded to include the construct of perceived behavioral control, in what we now know as the theory of planned behavior. Specifically, the theory of planned behavior postulates that attitudes, subjective norms, and perceived behavioral control jointly influence intention, which still serves as the most proximal determinant of behavior. Notably, perceived behavioral control is also hypothesized to directly affect behavior. Attitude refers to positive or negative thoughts concerning the behavior. Sense of subjective norm refers to the degree to which an individual feels social pressure to perform the behavior. Perceived behavioral control refers to the probability that the person can perform the course of action, and it is the same as self-efficacy. This reflects the fundamental difference between the theory of reasoned action and the theory of planned behavior. According to the theory of planned behavior, physical activity intention is defined as an individual's desire and motivation to be active. Attitude refers to the perceived consequences, positive or negative, of physical activity participation, representing a function of behavioral beliefs like perceived advantages and disadvantages of physical activity participation and evaluation of behavioral outcomes. Subjective norms reflect the perceived social pressure from significant others to engage in an active lifestyle and functions on the basis of normative beliefs like perceptions about whether certain individuals encourage or discourage physical activity participation. Lastly, perceived behavioral control reflects both self-efficacy like situational self-confidence for initiating and maintaining physically active behavior and controllability of the behavior like perceived ability to overcome physical activity barriers. As a result of the aforementioned considerations, a basic hypothesis can be postulated for the theory of planned behavior. Namely, an individual's intention to perform a behavior increases if they possess favorable attitudes and subjective norms, with concurrently strong perceived behavioral control. The social cognitive theory is one of the most frequently used theoretical frameworks used at this level of physical activity and health promotion to explain individuals' physical activity correlates and behaviors. This theory proposes that the behavior, the individual's environment, and the individual continuously change and simultaneously influence each other in a relationship termed reciprocal determination. Specifically, reciprocal determinism means that an individual can be both an agent for change and also a responder to change. Therefore, three factors: personal factors, environmental factors, and behavior must be considered when trying to understand individuals' physical activity behaviors. The application of the self-determination theory has been fruitful to explain individuals' motivation at different levels and achievement behaviors in education and sport settings. 3 innate psychological needs for autonomy, competence, and relatedness need satisfaction are central concepts within self-determination theory. According to the self-determination theory, 4 factors are considered important for situational motivation to understand the initiation and regulation of behavior, namely, intrinsic motivation, participation in activities for their own sake; identified regulation, behaviors that occur when individuals accept certain activities as important to their personal goals and values; external regulation, actions that are carried out in order to gain an external reward or avoid punishment; and a motivation, a lack of intention and a relative absence of motivation. Both intrinsic motivation and identified regulation represent higher levels of self-determined motivation and lead to positive consequences. while external regulation and motivation refer to low levels of self-determined motivation and lead to negative consequences. Popular stage-based approach applied in physical activity contexts is the trans-theoretical model. Within the trans-theoretical model, individuals are posited to progress through a series of stages, with each stage consisting of different behavioral and psychological patterns regarding the adoption of a health behavior. Specifically, individuals are classified into one of following 6 stages as assessed by their readiness to engage in behavior change: pre-contemplation, contemplation, preparation, action, maintenance, and termination. In the pre-contemplation stage, a person does not intend to make any behavioral change. This reluctance to make a behavior change may be due to lack of information and/or motivation. Regarding the second stage, contemplation, we see an individual beginning to think about changing their behavior within the next 6 months, often weighing the pros and cons of changing the behavior. Of note, individuals in the contemplation stage are not yet ready to take action to change the behavior. An individual is ready to take action to change a behavior within the next month after progression to the preparation stage, and typically have a plan for how they intend to change the behavior. Action represents the 4th stage of behavior change and refers to an individual using their previously developed behavior change plan to begin actively changing a behavior. Notably, the action stage is the most variable, with individuals at greatest jeopardy of regressing to an early stage. If an individual does not regress to an earlier stage when in the action stage and successfully adheres to their behavior change plan for 6 months or longer, these individuals will then be classified as being in the maintenance stage. The major focus of the maintenance stage is relapse prevention. Only when and if relapse is successfully prevented and the individual states they have no desire to go back to their old behavior and are comfortable engaging in their new behavior, is the individual said to be in the termination stage. However, most individuals who have changed their behavior stay somewhere in the maintenance stage. According to trans-theoretical model, as individuals progress through each stage, it is important to tailor intervention strategies to address the different psychological and cognitive needs characterized by each stage. Notably, however, the model is not linear, meaning individuals do not progress systematically from one stage to the next. Rather, individuals may enter any stage but relapse to an earlier stage, beginning the process again. Thus, designing stage-tailored interventions which meet the stage-specific needs of individuals will not only increase intervention adherence, but will also alleviate reluctance to initiate participation in the desired behaviors.